sort of share some like housekeeping notes and how we're going to go about today, and do a little intro. We are not going over an hour. So just time-wise, respect everybody's time. But some of the basics with Zoom, I don't know if everybody's done it or not. There's ways to mute and unmute. You can also turn off your camera if you want. So the choice is yours. I do have the master way to mute everybody. So if there is some back noise, I might mute everybody. If you want to speak specifically, we're going to do questions at the end. So maybe write it down or think about it, or hold it on. If it's really feeling like you need to talk about it right then, you can there's a way on the bottom to like raise your hand. So you can certainly do that. And I am recording the video. I just want you to know, but the way the recording works, no, I just started it, 1, so no private information has been shared, 1. 2,
I don't have any makeup on for this.
No, it only records the person who's talking for video. So if you're not speaking and being recorded is intimidating to you, I really respect everybody's privacy. So I want to let you know that you have multiple choices. 1, you can not speak. You can type a question or concern or thought. There's a chat option on the bottom. You can also, so not speaking is 1. You can turn off your video. That's another one. And then the third is at the end of the meeting, you can tell me. And if you are on video, I can crop you out and take you out of it. So I just want you guys to know that the real purpose of recording is for me to record me and my part and not you and your parts. And then this is supposed to be a safe space. Infertility and going through it is really hard for all of us. A lot of people do it under a cloak of secrecy. So we respect everybody's privacy. Whatever's talked about here, please keep that, to yourselves, recognizing that we all are fighting a similar fight, and want to make a community where we support and help each other and lift each other up. So please just keep that in mind. As for me, if I'm new to you, my name's Kristin Dillensnyder, or better known as Kiki, and I went through infertility. I did 3 rounds to have my daughter, and I now am an infertility coach. So I spend my time helping women like you who are going through infertility treatments to make the most of it, to make it a better experience, to be able to handle the weight, to know that you're not alone, to have somebody to hold your hand and walk alongside with you. Because if you're like me, the whole time I went through infertility, I would do anything to talk to somebody who understood and who knew, but who had also been a couple steps ahead of me, who wasn't under like the influence of the medicine and the hormones at the same point or same stage. So there's no competitiveness, and just knowing that there was the perspective of experience. And so that's what drove me to become an infertility coach. So that's me. And I actually met Dr. Likes because one of my doctors now works with him in Greenville. And so she made the introduction to the 2 of us, which is really cool, sort of small world. So I'm going to just pass the baton to Dr. Likes to take it away for his part.
All right, great. Thank you. So I do see some familiar faces, and I really appreciate y'all being here. I'm going to introduce myself just like Kiki did, and then I'm going to go into some topics that I've written down. So if you see me looking down, that's why I don't want to miss anything. But again, I'm Creighton Likes. I'm originally from South Carolina. I went to medical school down in Charleston. I actually did my residency up here in Greenville in OBGYN, and then I went to Duke for fellowship for 3 years. And then I've been back in Greenville since that time. I've been back going on 10 years now, so almost a decade. So that's my schooling, my training and history. I love Greenville. I love my patients in Greenville and beyond. So again, I appreciate y'all being here. I do want to preface it by saying that, 1, with this whole COVID pandemic pause, as I've kind of labeled it, we really appreciate y'all's patience. I can speak to my patients, obviously, but also those patients of other doctors. It is very difficult. We understand it, tremendously difficult for y'all. It's also very difficult for us, so we appreciate your patience. You are not alone, nor are we as clinics alone in terms of what we've done with this pause. I actually was on a webinar this afternoon with a buddy of mine who's a physician up in New York, so at the epicenter. And they're saying that his numbers showed that almost 90% of the fertility clinics in this country push this pause button. So you can imagine how many cycles have been affected. So you're definitely not alone in that situation. The other thing I'll say before I go into my topics is I think this field, and I've said this to a lot of my patients, this is a field that's, it's a lot of individualized medicine. So we don't have patients that fit in one box all the time. And so I say that to preface what I'm going to say, because the topics that I'm talking about are fairly general. So it's hard for me to specifically say to each one of you that this is what you need to do, but certainly in this waiting period and trying to optimize, you'll hear me say that probably a lot. My patients hear me say that a lot. That's what I'm talking about. And so just know the caveat to all this, that I do think this is a very individualized treatment protocol for patients in this specialty that we're in, which is a good thing, quite honestly, because it's, I think individualized medicine is important. And then finally, my topics in this waiting period are going to talk about both IVF patients who have pushed the pause button, but also non-IVF patients. So those patients who are doing, say, Femera ovulation induction or intrauterine inseminations, IUI. So we're going to include all of those folks. It's not geared towards one of those types of protocols or treatment cycles. So what I'll start with is my topics that I'm going to talk about. And Kristin and I are going to do about 10 to 15 minutes each, and then again, open it up to questions and answers. So I'm just going to start off with the first topic that we oftentimes will ask about when we first meet new patients, and that's your menstrual cycle. So cycle tracking. So in this waiting time, what I oftentimes will tell patients is get an idea of basically taking what's called a menstrual diary. What are your menstrual cycles doing? Are they regular? And so obviously, if you read the books will tell you a menstrual cycle is 28 days. Well, hardly anybody is 28 days. We understand that. What is regular for you is what you have to figure out. If it's 29 days, if it's 27 days, if it's 31 days, that's still okay. But what's regular for you, and keep track of that in this time that we cannot do cycles. The other thing about your cycle is the length of it in terms of how long your cycle is on for. Has that differed from where it was, say, 5 months ago? And if it's regular, is it differing that way as well? Was it 3 days before and now it's 6 days? Those sorts of things. And then finally, the flow. So oftentimes patients will say, my flow is heavier, my flow is lighter. Take note of that as well, because when you tell your physician that, your fertility doctor that may throw up a red flag to them to say, well, something could be going on from an ovarian function standpoint that can impact your cycle. And if it impacts your cycle, therefore, it can impact your fertility chances from both natural conception, but also any kind of stimulation protocols, IVF or non-IVF, that we do. And then the other thing I ask all the time is, are there any specific changes to any of those parts of the cycle that I just mentioned? So length or regularity for certain. Is it shorter distance or time between the start of one cycle to the start of the next cycle? All of these things will tell us, kind of give us a red flag in terms of saying things could be different with your endocrine profile, your ovarian function, your ovarian reserve or egg number. And make sure you notice that in this time frame that we're on pause to see if anything's changing. And then finally, with your cycle, we ask about spotting. So spotting in particular, some patients will tell me they have spotting around the time they're ovulating. Some patients will tell me they have spotting for 1 to 5 days, whatever the case may be, before they start full flow. That's another important part of your cycle to take note of and to let your fertility doctor know, because spotting prior to the start of full flow of your cycle can also throw up a red flag for us in terms of potential, for instance, for progesterone issues after you ovulate. So keep track of your cycle, keep track of any changes, and keep track of something that's just not normal for you. And when cycles resume and you go back to your physician, make sure you mention it to them. Okay, so that's your cycle tracking and kind of what we ask our patients to look for, and what we ask our new patients all the time, because if they're new to us, we don't know what they've been experiencing. But in this time, take note of that. The next topic are the testing that you can do at home. So a lot of patients will come to us and say, I do basal body temperatures, and I've done them for 6-7 months or more. They bring out their Excel spreadsheets and they show us their basal body temperature. I think that can definitely work for some folks. I will also say that sometimes that can be extremely frustrating for some folks. Basal body temperatures have been around for years. They're in all the old textbooks. I will tell you, when patients come to me that say that they've done that for 6 or 7 months, I will tell them, stop doing it. It's only stressing you out. It is exceedingly difficult to get right. I'm not saying you're wrong in doing it. Please don't think that. I'm just saying it can be very difficult and cause further anxiety or frustration because your temperature can only fluctuate a few tenths of a degree to see if you're ovulating or not. And any movement out of bed can cause a tenth of a degree or so temperature change. So just keep that in mind. Take those with a grain of salt. The other thing that a lot of patients do, and we have patients do, are ovulation predictor kits. I'm sure most of y'all, if not all of y'all, are aware of OPKs. Everything has an abbreviation in what we do. So OPKs are used very commonly. I would ask that, honestly, in this pause, that you perhaps do those if you haven't done them yet. But this also goes back to what I said in terms of tracking your cycle, because if your OPKs are showing positive, one, that's great. The caveat to a positive OPK is there's about a 15% false positive rate. So knowing that, just keep that in mind as well. But if your cycle day that you're getting your ovulation predictor kit positive is changing, that's another thing you should probably tell your physician as well. I ask all the time, because patients, again, will come to me, they've done these OPKs, and I ask them, what day are you getting the positive for the OPK? And since they're coming to me, obviously they're having some difficulty conceiving. So a vast majority of folks will tell me, yeah, my OPKs are positive cycle day 16, 17, or 18. And to me, and some of my patients know this, I tell them, I don't think it's not that you cannot get pregnant with your ovulation kits that positive on those days. It's just that I think there's something that can be optimized if you haven't conceived and you're still consistently getting those OPK positives that late in your cycle. And so again, in this time of pause, if you're doing the ovulation predictor kits, take note of what day of your cycle you're getting a positive, and has that changed compared to what maybe you did 5-6 months ago. And so just for clarity, and I think everybody knows this, cycle day 1 is full flow, and so you count from there. So when I say cycle day 16, it's cycle day 16 from full flow is what we're talking about. So those are the testing at home, over the counter sorts of things that we hear patients do, and those are my kind of pearls for that. The next topic is intercourse. I mean, if you're trying for timed intercourse and trying to conceive naturally, you hear me say optimization. You've heard me say it a few times. This is no different. The other thing I talk about with this is timing. Everything we do is time dependent. Intercourse is not different. So just something some folks may not know is the optimal time to conceive is to have intercourse 48 hours prior to, up to the day you ovulate. If you haven't had any kind of intercourse prior to the time you've ovulated, and then you try after that, the chance of pregnancy is probably less than 1%. So timing of intercourse is important based on timing of ovulation. So that goes back to everything I've already said in terms of menstrual tracking, ovulation predictor kits, those sorts of things. And if it's not happening for you, then that's where we come in terms of trying to optimize that time, and maybe perhaps when the cycles get going again from the pandemic, we can say, okay, here's probably when you need to start having intercourse, and here's where you need to, in terms of your ovulation predictor kits. The other thing I'll tell you is, empirically, if your cycles are regular and you think, well, I'm probably ovulating in mid-cycle, it's probably normal. Because of that 48-hour window we just talked about, we oftentimes will tell patients or couples to start having intercourse around cycle day 10 of their menstrual cycle and have intercourse every other day. You can have it both days in terms of around the time of peak ovulation, that's okay, but usually we say every other day for a total of 5 times. So that's not 5 times a day, that's every total of 5 times in that every other day time span. And that usually, if you're regular, will have the timing that we're talking about 48 hours prior to when you ovulate. So the next topic I was going to talk about was kind of wellness and diet and exercise, and I think Kristin's going to talk about this as well a little bit. And I will also preface this by saying I am not a nutritionist. I know nutritionists that do fertility nutrition, so I would defer to them for sure. But in terms of wellness, diet, exercise, those sorts of things, and during this time of pause, I can say this to myself if I looked in the mirror, this is a good time to get everything kind of, quote, in shape. So diet and exercise, you hear doctors say that all the time. It's probably one of the more difficult things to talk about. It's one of the more difficult things to probably do during this pandemic when we're all stay at home, but it is important. I mean, you hear in terms of from a weight standpoint, obviously for general health issues, but from a fertility standpoint, there are weight issues that we talk about, not only overweight, but underweight, quite honestly. And there is a quote sweet spot for BMI, so body mass index, which takes into account your height and weight. And usually the BMI range we talk about is the low end being 17, 18, the higher end being 26, 27. And if you look at a BMI chart, once you get over those numbers, then you're actually classified as either overweight, or if you're under those numbers, underweight. And so there's this proverbial sweet spot, and we try to, again, think about that from a diet and exercise standpoint. In terms of diets, we talk about, there are a multitude of diets out there. Chris and I were actually talking about this before we got online. I don't endorse any one of them. Obviously, whatever's right for you is what you need to do. I will say everything in moderation, but things like high in fruit and vegetables, low trans fats, those sorts of things. And again, a nutritionist is going to be the one to really guide you, because everybody probably has a different body type and a different demand for their body. But I would typically say things in moderation. Obviously, in this time, at the pause, we talk about alcohol consumption and smoking. We talk about that all the time, not only during the pause, but smoking cessation for both men and women. Oh, and the last topics are both for men and women, by the way. Smoking cessation is important from a male and female aspect. We know that smoking and nicotine can cause issues with sperm production, sperm function, but we also know it can cause issues with egg quality. And so, you could be hampering yourself from that aspect as well. So obviously smoking cessation, and then alcohol consumption. Again, moderation. I'm not going to say you need to stop all alcohol, but things in moderation, because in excess can also affect sperm and egg quality and production. And so just keep that in mind as well. In terms of going back to weight loss, we talk about 5 to 10% of your body weight. If you're overweight, we talk about if you can lose 5 to 10%, that may actually improve your chances of ovulation or ovulating on your own. Again, going back to the first few topics I talked about, because of how endocrine and hormone pathways are in obesity, if you lose the 5 to 10%, you may actually see a resumption of regular cycles, a resumption of ovulation, and then obviously potential for conception naturally, or enhanced conception with optimization from medicines and things that we do. The next topic is a hot topic, I think, and it's supplements. So over-the-counter supplements. I know all of you know these. I know there are a multitude of supplements out there, and you all could probably list them as well as I can, like Fertility and other things. I will tell you, there are supplements that have had some studies behind them, and then there's a lot of supplements that have not had rigorous studies behind them. No supplement or vitamin, I will tell you, is FDA studied, or there are no randomized controlled trials for supplements in terms of effectiveness. And so you have to take those with a grain of salt. That being said, we put and have a lot of our patients go on supplements because, like I said, there are some that have shown promise. And a lot of these are in the antioxidant category. And then there's also coenzyme Q10 or CoQ10 or ubiquinol. It goes by all these names. These are all over the counter, and we have all of our patients go on a number of, I see nods of heads, a number of vitamins and supplements, and I'll list them for you. I'm not going to list the dosages because we'll just post that, because that would be tedious. But the ones that we really focus on are the coenzyme Q10. We do think that can help oocyte or egg quality. So CoQ10, and it's again over the counter, vitamin C, vitamin E, and certainly if you're vitamin D deficient, which you would be amazed how many millions of people around the world are vitamin D deficient for various reasons. If you're vitamin D deficient, definitely taking a vitamin D supplement is going to improve. There are actually studies on that in PCOS women in terms of quartiles of their vitamin D level and that efficacy of supplementing in their fertility. So vitamin D is another very important one. And then along the lines of the PCOS, the inositols. So I talked to a patient this morning actually about the inositols. So, and there are a multitude types of those over the counter. There's D-chiroinositol, myo-inositol, ovasitol. So just keep those in mind as well. And most of these you can go by what the label says in terms of dosage, but some of them are a higher dosage than what's on the label, and that's where I'll write that down for you. And then finally, some folks will, based on their lab work and based on their evaluation with us, we may put them on DHEA, which is a hormone that it's a precursor to a lot of other hormones, but we see that in lower ovarian reserve, older reproductive age folks may need DHEA. And I'll tell you, the studies on DHEA are like a sine wave. Sometimes it's real popular to take, sometimes it's down and say, well, that doesn't do anything. We just don't think it'll hurt, but we do it based on the evaluation we've done from a lab work standpoint. And then obviously, lastly, prenatal vitamins. I think that goes without saying, but you'd be surprised how many patients, again, I just talked to a patient this morning who's looking to conceive in the near future, and she's not on prenatal vitamins. So I say definitely start a prenatal vitamin before you start trying to conceive. So you go ahead and have those on board. In that same vein, timing. Some of the vitamin supplements take a while to see an effect. What I mean is, if you look at the maturation lifespan of a sperm and an egg, it literally takes 70 to 85 days from start to finish. And so, for instance, when men come in to do semen analyses, our andrologist will ask them, okay, what were you doing basically 90 days ago? Did you have a fever? Were you sick? Anything? Were you in a hot tub? Those sorts of things, because 90 days ago will affect the semen analysis today. So it's not different for women. 80 days ago will affect what the egg is doing when it's ovulated. So keep that in mind in terms of getting these things on board from a supplement standpoint to take effect in the future. And then the last topic I was going to talk about really is the testing. And so even though we are in, like I said, this quote, pandemic pause, we are able to do certain things now in preparation for when when these restrictions are lifted to better optimize your chances. And so I will also tell you that we have kind of relaxed some of our patient interaction, because again, with this COVID restrictions, we're trying to limit patient interaction into the office. But I will also say we're probably in South Carolina, and this is info that I just got, we're probably up in the upstate. We're probably at the peak or just past the peak. So that is exceedingly good news. Now, you know as well as I do, that can change in a matter of days, in a week, and we could hit another peak. I don't know. But having said that, we are relaxing some of the restrictions. And so we are able to do lab work in terms of timing. And we can either have you to go to a lab somewhere close to your house if you're outside of Greenville or wherever, or we can have you come into our office, and it literally takes about 5 minutes. So with social distancing, we do all that stuff, but you can come get your blood drawn. And what those blood evaluations are doing are giving us an idea of where you stand now, again, from that endocrine standpoint, your ovarian reserve standpoint, those sorts of things, to get us prepared and you prepared when the time is ready to move forward with stimulation or whatever their cycle plan was. Another thing is we are now doing ultrasounds for GYN reasons, any history of any abnormalities, ovarian cysts, uterine malformations, those sorts of things. We're doing ultrasounds to evaluate that. And we're doing 3D sono ultrasounds or sonohistograms, which is a uterine cavity evaluation. And these are done in the office. And again, they literally take 3 to 5 minutes. And I think some of y'all have probably had those and you know what I'm talking about. But things change. We do those every 6 months. If you haven't had one, we will repeat it because things can change to make sure there's nothing there, again, to optimize when time is right to start stimulation. We are not doing HSGs just yet, and there's a multitude of reasons for that. So that's the dye test of the tubes. So that's still on pause right now from a staffing standpoint and logistics standpoint from where I am. And I know other centers are doing that as well, putting that on pause still. And then the semen analyses. We are now opening slots for semen analyses for the male partners if that's needed. And so you can honestly just call us and we can have semen analysis scheduled as well. So again, in preparation, because what I don't want to do and what I tell patients all the time, I don't want to just focus on in a heterosexual couple, I don't want to focus on just the female partner because 30% of the time it's a combination of factors. And so if the husband or the male partner hasn't been tested, they need to be tested and that can alter our protocol. And again, when we're ready to stimulate, that can change what we do. And then lastly, we're doing a lot, such as the Zoom conference right now, we're doing a lot of telehealth and it's gone very, very well, I think. I go to my office typically, but some doctors will do it from their home. But telehealth appointments, again, to kind of reiterate these topics I've talked about, but also to get a more individualized treatment plan. I recommend or strongly encourage you to consider those telehealth, again, to get ready for your cycle start when these restrictions are lifted. So those are my topics. I know it was kind of broken up, and I apologize for that. The only last thing I'll say, if you're on an IVF pause or a frozen embryo transfer protocol pause, I would have you stay on whatever supplements or medications your physician has you on, again, in preparation for when these restrictions are lifted to just move hopefully seamlessly into the cycle, so you don't have to wait another menstrual cycle or wait another whatever amount of time because you've already waited long enough. So again, remember, you're not alone in this. 90% of fertility clinics in this country have stopped cycles, and it's very, very difficult. But I'm hoping we're over the hump and we're going to start back in the next week or two with cycles.
Okay, that's awesome. Thank you. So we're going to do Q&A sort of after, but I'm going to share my aspect, the emotional aspect of what to do while you're handling the wait. It sounds like the wait won't be as long, but everything I'm actually going to share and talk about is really not necessarily specific to right now. It's how to handle waiting in general. Because what I found through my experience is that going through infertility, you wait for every next step, every stage, every milestone. And then even when you get the positive pregnancy results, it's like the beta, the numbers have to grow, and then it's the ultrasounds, and then it's the trimesters. And so we are always waiting for different stages and steps. And so it feels like forever because of that. Right now, because of the pandemic pause, it's adding another layer, which makes it really hard. And I'm so glad to hear that the clinic is opening up and starting to make progress. But what I want to share with you today is what to do and how to handle when you find yourself in these moments of wait, and help you also understand why it kind of stinks so bad. So I also have notes. If I'm looking down, it's just so I don't forget anything, especially because I'm going to try and be a little bit faster. But there is a ton of nervous energy that comes with waiting, because, especially going through infertility, because you want it so badly. And it's a moment of uncertainty, and there's no guarantees, and you have lack of control. And all of those together are what make people feel anxious and what put people in such a hard position during moments of waiting. And so what I want to share with you today is when you feel like you're in moments of waiting and there's nothing you can do, the key is to actually put all of that nervous energy into the things that you can control, which sounds silly because you have the sense of no control, but I'm going to remind you of what you can control. And my hope is that tonight and tomorrow, you will pick one of these things to start implementing in your world today. Habits take like 21 days to actually become a habit. So of the items I talk about, pick one thing. Pick the thing that sounds the most interesting to you and add it into your world and try it for 21 days before you start adding another one. Otherwise, you're going to sort of feel a little bit overwhelmed. All of these things are free, simple, easy. They sound so basic, but the implementation of it and the consistency of it really makes a difference, because like what Dr. Likes was talking about, your whole body, like the whole aspect of the patient is what matters. And everything has little parts to impact your success. And while we can put a lot of the pressure on our doctors and the medicine that we take to get us there, there is a whole other aspect to consider, and that is your mental health and your emotional health. And like you said, your body in a general sense with food. So what you can control are the things that you consume. The easiest thing is food. And like you talked about, nutritionists are way better. But I like to think that we always know what we should probably do or not do related to eating. None of us, I think, live under rocks. But it's really about making the right choice. And so what I help clients with, or we talk about a lot, is the choice I'm making now and what I'm going to consume, is it going to help me now or is it going to help me later? Will future me thank me? And so that's just one thing to think about when you're choosing the foods you eat. One of the things that you consume is drinking water, which sounds so simple and easy. And I guess if you listen to anybody else, a lot of other people are talking about this, but drinking half your body weight in water is a really simple way to keep your body moving and functioning at its best. You're supposed to do half of your weight in ounces. Is that right? So if you weigh 150, 75 ounces is how much you should drink in a day. So that's an easy thing to track and monitor and do. And again, it's free. Try it for 21 days before you knock it, honestly. The other thing that you consume is the news, the media, the social media accounts you follow, the TV shows you watch. All of those make an impact on your mood and your emotions. So really evaluate them. If there's somebody you're following and they make you jealous because they're always sharing the life you wish you had, maybe it's time to unfollow them and not watch them. Follow accounts that make you inspired and motivate you. Don't listen to the news, especially with all this stuff that's going on that's talking about waiting and terror. And it's okay to stop that bad stuff. So think about the things that you're consuming in your body. The other thing that you can control is what you're doing each day. So the number one thing are daily habits. And I talk about 5 daily habits. So these are the things. Pick one. Following a sleep schedule. It sounds crazy, but sleeping consistently and going to bed at the same time is, oh yeah, sorry, I just saw that note. I wish I weighed 152. That's funny. Okay. Going to bed at the same time and waking up at the same night really sets you up, and having a routine can really make a difference, and it sets your day off on the right foot. So a sleep schedule is one of them. Moving your body. Listen, I did run a marathon once. I'm never doing it again. I'm not telling you to go run, but moving your body sort of changes your mind. There is like the physiology behind it. Every day, if you move your body, if that's walking your dog, if that is doing yoga, if that's stretching, it doesn't matter what it is. The wonderful thing is you can do the things that you love, and whether you're stuck at home or not, there's so many options. But moving your body helps change your mind. It gets you out of funks. It gives you something to do and be consistent with. And all of these habits, the reason why I talk about and work with these with my clients is that these habits sound so simple, so easy. But when you are having a really bad day, when you get really bad news, you don't want to get out of bed, right? It's hard to make good choices. It's hard to put yourself first. You feel so bad for yourself and your situation and the why me. And if you add these 5 daily habits, and they're non-negotiables, they're things that you do every day, whether you feel good or not, it is what can get you out of bed. It is what that can turn your day around. And it's what can make you feel like you're making good choices to impact your future, which will impact your success, which will impact ultimately your happiness. Making your bed sounds so silly, but I heard the coolest phrase. It said, the state of your bed shows the state of your head. So think about that. What does your bed look like, and what does your head look like, and do they match up? And starting the day by making the bed is a really simple, free thing that you can do, but it's a completion. You've started your day by doing something. And that is, honestly, it sets one step of doing something good, sets you up for another thing to do something good, and another. The other ones are a daily practice of gratitude. There's different ways to do gratitude. The best way is to write it down. And the key with gratitude is to think of things that happened in the last 24 hours. So we are all thankful for our families. You know, we're all thankful for those things. But think of things that happened in the last 24 hours. And gratitude, again, sounds super fluffy, but what it does is it keeps you present in the moment. It makes you recognize the good that's around. When you see and look for good, you find other good. When you're thinking about, oh gosh, everybody else around me is pregnant, you're going to see everybody else around you pregnant and not you. But when you start thinking about good things and looking for good, you're going to see other signs and symbols that are going to remind you that this is good. And then the last one is journaling, meditating, or praying, or all of the above. But spending time to be calm in the moment. All of these things help your body, they help your mind, they help your emotions, They bring you back to center, they focus you, and they put you in control. Because the lack of control is such a common feeling that we all have. And I love that Dr. Likes shared real, tangible, practical things that you can do related to like the medical side, right? He's the expert. He's the expert. I mean, how cool that he's here. I love that. And the things that I'm talking about sound so simple and basic, but I went through 3 rounds and every single one of them was different. I had a different outcome all 3 times. And I had the experience of knowing what it's like to go through that process without doing any of these things and trying all of them. And I'm using them as a reminder to myself right now through this pandemic, because this feels wildly weird and crazy. So every day I'm doing my daily practices and they give me purpose and a sense of accomplishment to be able to handle anything else for the day. So no matter if you're dealing with waiting for infertility or being pregnant or another thing, all of these tips are really going to help. So I really encourage you to pick one of the things that I've talked about and try it. Try it tonight and try it for 21 days and then let me know. And you can be like, it's BS after 21 days. I don't think anybody will do it if you really try it. But that's what I wanted to talk about just for the sake of time today. And so that being said, Q&As. Do you guys have questions for either one of us? Feel free to unmute yourself and ask away or type it. But we're here. We're here because we want to support you, and we want to let you guys know that even though you're in the wait and paused and things are on hold, that there is stuff that you can do. And so yeah, ask away. Yes, Elizabeth, go ahead. You're mute. Okay, there you go.
So my question was for Dr. Likes. This was just something that my husband and I were talking about, but never mind, because you kind of already answered it. Sorry.
Well, that's a good thing. That's what talks are supposed to do, right?
Well, you kind of, you were saying maybe like a couple weeks, perhaps, depending, for starting transfers again. My question was just going to be like, are you against or for trying naturally while we wait for that time? Or sorry, go ahead.
No, are you finished? I didn't mean to cut you off.
Well, no, we were just talking because it's like, we've spent all of this money and we know we have a perfect embryo waiting on us, and like because of my age, and we were just trying to weigh things or whatever.
It's interesting. That webinar I was talking about that I listened to at noon today, they actually touched on this point because part of the pushback from the guidelines or the recommendations from the American Society of Reproductive Medicine, ASRM, which is our governing body, part of the pushback from a number of fertility doctors was, we think infertility is essential, and people aren't being told not to try on their own, like you're saying. In fact, he brought up a picture of Dr. Oz saying, yeah, people are fine to try to have intercourse and try to have a child right now. I mean, I would think, and I've told patients this, that, if it happens, I don't think that's a bad thing. Actively pursuing it, I don't think that's a bad thing either. Obviously, it's going to depend on what kind of evaluations you've had, and if it's any of the risk factors that we had discussed, if you had been seen by a fertility physician, aren't going to be thrown out the window, so to speak. But I think it's okay to try. In regard to the COVID pandemic, because that's the big question that everybody asks, if I get pregnant during COVID, the bottom line is we just don't have the data or the numbers to tell you if it's going to be a potential bad outcome. We have no data on early first trimester pregnant folks, if it's any possible harm to the pregnancy, to the fetus, or to the mother. We just don't have that, like we did with H1N1, if y'all remember that, 12 years ago, where it was horrible for pregnant women. And so we don't think it's that. I can tell you those numbers aren't showing. So it's kind of an unknown, but that's what I tell patients. And I've had this conversation within the last week a number of times of patients who may get on Femara to try to regulate their cycles, to optimize their readiness for their when they come back, but know that they could get pregnant if they ovulate and they have timed intercourse appropriately. So those are kind of the caveats I tell you. On the flip side, I just counted that we have a number of early OB scans all this week and all next week. So, I mean, it's happening. on their own as well. Some of these were treatment cycles from the past, but some were on their own. So I would say, yes, it's okay to try. Let's put it that way. And just knowing that there is a little bit of unknown there.
Okay.
I have a question regarding the semen analysis.
Okay.
So my husband got a semen analysis maybe almost 3 years ago, and he hasn't gotten one since. We've just been working with my OB. I was supposed to have my first consult with an RE March 18th, and then all this happened. But they told me that they could still test the semen analysis next week, or they could do it in May. Is that something that we should do now and then later, or does it matter, since you were talking about how it's just different?
That's a good question. And I won't pry into your previous testing, but if it was normal, if it was normal or abnormal, I would say yes, go ahead and get it tested if it's been 3 years.
Yeah.
The reason
now in April and then in May?
No, just now.
Just now. Okay.
Just to go ahead and have it done. Because again, should something come back numbers wise showing a little bit of either low concentration, low motility, whatever the case may be, you'll know that moving forward. And once these guidelines have hopefully relaxed, that may tell you, well, maybe you do need to look into IUI, or if it's significant, maybe you do need to look into IVF. And so I would go ahead and have it done, quite honestly.
But 3 years ago it was morphology, but they only did one. So they haven't tested him again. Yeah,
and I tell patients that all the time. There are definite fluctuations in semen analysis parameters from one test to the next. I almost universally, if they're showing some low parameters, I don't care if it's one parameter or two or three, I say we're going to repeat this because they definitely can fluctuate from one analysis to the next. So yes, I would repeat it.
Okay, thanks.
Sure.
I have a couple of PCOS questions.
Okay.
So specifically, you said at home. So I've been told most of the infertility is probably coming from my side because of PCOS and endometriosis, because of the semen analysis generally being normal, maybe slightly low morphology, but not significant, right?
Sure. Right.
So you mentioned testing at home with the ovulation predictor kits. And I've been told by doctors in the past that with PCOS, they are not really accurate because you have multiple LH surges just because you have a lot of immature follicles that could be present.
Yeah. So I hear what you're saying. And I don't think you're wrong. Historically, I wouldn't say you have LH surges, but you have most likely a higher LH at baseline. Okay. Historically, one way that we tested to diagnose PCOS with lab work is to test an LH to FSH ratio. LH is obviously the surge you're talking about, the luteinizing hormone from the pituitary. And historically, we said if the LH was 2 times greater than FSH, that's PCOS. That's kind of gone to the wayside now, but that just speaks to your point that yes, it could be a higher baseline LH. And that's probably why there is a false positive rate, as I mentioned, on ovulation predictor kits. That may be contributing. You're absolutely right. And that's why I said you just, in this time of pause, maybe you can try them and see if it changes anything. I will tell you, as I tell a lot of my patients, once you come to us or me, and we're going to start doing active cycles, whether it be IVF or not, I'm probably going to tell you, don't worry about the ovulation kits anymore, because we're going to hopefully take care of that and control it a little bit anyway.
And then one other, I guess I have 2 other, but so you probably going to say this wrong, but you mentioned a supplement for people who have PCOS specifically. Yes.
Yeah.
If you are an IVF patient, is that something that you should consider taking, or is that only if you're trying to conceive with like Femara or IUI?
Yeah, that's a good question. That's a good question. So I would ask you back, you don't have to answer this, if you're on metformin. I didn't even mention that, but that's another medicine we put a lot of patients on that we think may have a PCOS type picture. Metformin, Inositols kind of, in a roundabout way work the same in terms of the end result, but it's just a different pathway. So I don't think you necessarily would need to be on both of those. You could try one or the other though. I don't think it's going to hurt if you're on both of them, but.
So patients who have taken these of yours, so I have taken metformin in the past and had significant side effects from it, just feeling like terrible all the time. Do you see that your patients have the same side effects from taking these supplements, or is?
I have not seen that. You're right. I mean, I don't know what side effects you have, but GI side effects are the major complaints we have with metformin. I don't know if you were on the extended release. There's a multitude of ways to do the metformin. I usually, if you have that, just do an extended release once at night and see if it helps. But I have not heard a lot of side effects with the inositols, I'll be honest. But I don't have the degree of patients on inositols as metformin. I'll tell you that as well.
Okay. The other question I have is that I have had significant weight gain with the medications that you take. Obviously, I haven't taken progesterone or estrogen or any of the others for almost a month now. And I just cannot seem to lose any weight.
Yeah.
And I'm not, my activity level hasn't changed. It just seemed to like stack on with the hormones, and diet and activity is still the same.
Right.
But nothing is improving.
And that's probably one of the more difficult things to answer, quite honestly, because there can be a multitude of etiologies for weight gain and difficult weight loss, or difficult to have weight loss. I will tell you, and if you're close to a cycle with the medicines that you do on an IVF or a frozen embryo transfer cycle, you're going to probably, everybody's different, caveat, everybody's different, but you're probably going to have a little bit of weight gain. Could that be from a hormonal water distribution? I hate the term water weight. I'm not saying it's water weight, but it's just a matter of what you hold on to differently with hormones, and everybody reacts differently. But also you have to consider, are there other reasons that's there? And if you're not changing your diet and exercise and you're doing it like you used to, well then, I know for certain you've had because I know Dr. Green, she's checked your thyroid and other things, but those things could be checked again as well. But I would just unfortunately say time is probably going to be the best thing. And the other thing I got to realize, and I'm probably the oldest one in this whole conversation, so I can say this, as we age, we're going to gain weight. Unfortunately, things change. And I don't say that to be flippant. I say that to be honest. But I would give it time, because I'm willing to bet you will go back down.
Okay. That's it. Thank you.
Sure.
Real quick, your stress level too. Look at that. That will associate weight gain.
That's good. Yeah. And I didn't mention stress, but that's a wellness category. And to the point of stress, and I say this all the time, it's hard for me to say, just go de-stress. I don't know what that means for everybody, right? Sorry, I'm outside. You may hear the rain starting. But we actually have a lot of patients do acupuncture. Some on this panel may have, and a lot of patients will do massage. So I have a lot of my patients do those two things. If for nothing else, maybe stress relief. Yes, there's some, from acupuncture standpoint, I'm sure, and I don't pretend to know the practice of acupuncture, but there are some studies that show that may be effective for fertility, because there are actually fertility acupuncturists in town that I know and personal friends with. And so to that point, that's a good point in terms of the stress. Now, I don't think you're going to be able to go get a massage or acupuncture right now. That's why I honestly didn't mention it, but that may be something that you could look into in the future as well, when those restrictions are lifted.
Well, and the stress thing is something that I work on with a lot of my clients too. And there's ways to make it better, and there's ways to make it worse. There's ways to not impact it at all. And, I love that meme that says like, tell me to reduce my stress and I'll punch you or something, like, because that's how it feels when somebody does tell you. But yeah, I'm glad you brought that up. So the stress is a part. It impacts all of it, weight and emotions and your success rate. So the things that I was talking about relate to the weight and all those habits. Those are going to reduce your stress too. really, because it's putting you back in the driver's seat. It's putting you in control, and it's you doing things, and you're going to see progress. You're going to see improvements. And so all of that will work together.
When you're talking about reducing stress, and I know we've talked about this before, Dr. Likes, but obviously one of the main ways that I like to decrease stress is by working out. Yeah, exercise. And so I always, and I mentioned this to you before, but I always worry about overdoing it in that category and messing something up, because it's the first thing I go to. You know, I would just run until I fall over, and I hate it, but it helps. So,
So, I mean, that's a good point too. You know, I go back to the wellness talk I mentioned in terms of that topic, everything in moderation, and everybody has a different level of threshold for moderation, right? I mean, historically, there is something called the female athletic triad. And that's where if you are an avid runner, like or a gymnast or a marathon runner, and you do this all the time, basically what your body does is it sees that as a constant stress mechanism, and it will reduce your gonadotropin release from your pituitary. And oftentimes these women won't have periods because they don't ovulate. Well, obviously, if you don't ovulate, that's going to affect your cycles. I think in these situations, again, moderation, yes, exercise is good. There's no doubt. I mean, both Kristin and I said that. Where your threshold is very difficult to say, but in these cycles, I don't think, and I can speak personally to you, I don't think that's a detriment right now. I will say, if you see, again, going back to what I said in the very beginning, a change in your cycles, well, then, you know, maybe you have hit that threshold and you're overdoing it, because your body will tell you sometimes. And that's one way of knowing it, because again, it's just a stress mechanism that the body sees, and it will shut down essentially non-essential things, components to sustaining life, and releasing an egg is not maximizing your life, right? So that's what your body does. And so you may see it change your cycle too, but I think you're fine.
On that note, so you're saying that potentially I've been running, okay, let's say you've been running a 5K every other day for the past month for the same reason, for stress, and your ovulation day changes by 5 days. That definitely has something to do with it?
I mean, I think it can, absolutely.
Okay.
Unless that was your tendency before you started running constantly. You know, I mean, if it promoted a change because you've changed.
I stopped taking letrozole at the same time that I started running that much.
Well, that could affect it as well. I mean, letrozole is going to hopefully help you ovulate more regularly anyway, right? And so I would just keep watching it. But if you've needed letrozole in the past to ovulate, you still may need that again, whether or not you run or not.
Well, and my doctor said what made it sense to me was just don't add anything new. You know, like if you've been doing it, you can keep doing it, but now's not the time. When you're pregnant is not the time to like start trying things, unless maybe it's like yoga or something. But I thought that was really helpful for me to be like, okay, if you're active, and if you guys are all in moments of pausing now, wait, like try something now so that it's a good, healthy thing. But walking also counts as exercise and helping you de-stress. And walking is usually like the safest thing you can do.
I have a question. So my husband and I had a miscarriage in January. And so I'm back on the tracks again, getting back into it. And I have to take Femara and progesterone every month. And I'm ovulating because I have to get blood work done. And my levels are like the highest they've ever been. But since then, I haven't gotten pregnant. So do you think there's like an underlying issue that I should ask the doctor about? Because you did say like if the days change. So like 1 month I'll be like on like day 16, but the next month will be like day 17.
And that's on the Femara?
Yep.
Yeah.
But that's taking it days 5 through 9.
Okay, that's my next question was that too.
Yeah.
There's nothing wrong with 5 through 9. I will tell you, I like 3 through 7. I have all my patients take it those days. Again, I think it's that timing mechanism. And I don't know, what your AMH is in terms of what your cycles are without Femara or anything like that. But I do think that can play a role in the timing and, like I said, the optimization. Because what happens is if you're cycling, your brain knows you're not pregnant before your body shows it with a period. Right. So it's already sending signals to recruit eggs. And so if you get that femera maybe a little bit on board earlier, it may enhance that and then get that window down a little bit more, because it's, like I said, it's nothing wrong with ovulating day 16, but in my mind, from a physiologic standpoint with the menstrual cycle, that follicular phase being that long, maybe something's askew, and therefore maybe something's askew with your implantation and those sorts of things. You know, that's one thing I would mention. The other caveat is, and I draw progesterones all the time on patients on day 21, 22, something like that, to see if you ovulated.
Yeah.
Draw your progesterone now and 90 minutes from now, and it can be different. And so you have to understand that too. But it is, I think you messaged me that your progesterones were good, and that's a very good indication that you're ovulating.
Yeah.
If it hasn't happened in 1 or 2 more cycles, I would probably take a look at your uterus.
Okay.
With that ultrasound I was talking about, the 3D sono ultrasound.
Would the HSG be something that I need to mention to my OB later on down the road, or?
I would not necessarily, because if you tell me you've been pregnant, I know at least one tube works, right? And so the HSG is mainly for the tubes. The 3D sono is mainly for the uterine cavity evaluation, and I think that's what I would go to in your situation.
And that's called what now? I'm gonna write that down.
Yeah, 3D. You can do sono, SONO. They'll know what that is, or you can. Another abbreviation is all caps SIS.
SIS. Okay. And I have one more question. Is there like any? Because of course, I guess with everyone home, like we have a 2-year-old, so he keeps us busy. But is there like any good podcasts that people listen to, or just something to get it off your mind? Because I feel like the more that we're at home, the more at least I think about it.
Listen to As a Woman by Natalie Crawford. She's awesome.
Okay.
Well, do you want like fertility podcasts or like de-stressing podcasts?
Both. Like I'm good at the beginning of the month, but like right now I'm at the end of my cycle, so I'm like, my husband's probably like, "Oh Lord, just let her restart her cycle again."
Well, I have a list of all the fertility related podcasts, and so one of the things that I was going to do was email everybody tomorrow to just say, thank you, probably apologize 4 more times, and then I can include the podcast list in it.
Yeah.
For anybody, and hopefully it shows you a few new ones that are out there. But it's a whole host of podcasts, which is really kind of cool. Like some are funny and silly, and some are more serious, and I'll interview doctors. So it's kind of runs the gamut, which is nice. So you can find what you're looking for.
Well, I want to tell y'all thank you, not just for me, I'm sure for everybody, but this is like a total therapy. So I appreciate it.
Absolutely. Thank y'all for being here. I will one last thing, unless anybody has any other questions. I don't want to cut you off. No, I mean, yeah, go ahead. Sorry.
I did, but I feel like I can just ask you like when I come in. So that's why I don't want to waste anybody's time.
That's fine.
No, you were talking about like, monitoring your cycle and whatnot. Well, I had my period after the failed first transfer, but now, and I was just emailing Susan and Sandy and everybody today too, I've got some just real not normal crazy things going on, and I honestly have no idea like what's a period, what's not a period, and I'm extremely just feeling like my body is shutting down or something.
Yeah, I don't think it's shutting down, but I think it may just be trying to get back to a normal routine, because once you go through what you've gone through, anybody going through cycles, the HPO axis, the hypothalamic pituitary ovarian axis, may take some time to reset.
Okay.
And that may be what you're experiencing. I don't think you're falling apart, Elizabeth. But
okay, this has been going on for like a week now, and I'm like, what is going on?
Yeah, we can bring you in if it keeps going, I promise.
Yeah, I have to email next Friday if it is.
Okay.
But I have another question. This is kind of at the other end of the spectrum. We've only got one embryo left, and I am just really, I don't want to start crying, but I'm just really concerned. There's just something wrong with me on the inside of why this isn't working. And I've heard people talk about like the ERA thing, or like, I didn't know if there was anything that we would change between now and the next one, because I really just kind of feel like I'm broken. Sorry, but
I understand.
It's been a rough couple weeks.
I understand. there may be something we can change. And why don't I just talk to you about that in person?
Okay.
Okay.
And Elizabeth, I've been there. You're not alone in feeling that way.
Been there.
Yep, no worries.
All of us.
Thank you, guys.
Yeah,
have
you're
a
not
quick-
alone in that.
Quick question about the 3D sono.
Yes,
Would you recommend that for somebody who's had a miscarriage?
I would. I would, just because I have seen where some what are called filling defects are in the uterine cavity. That's really the best way to visualize it, and that can be usually very easily correctable.
Okay, thanks.
Yep.
I have a question too. It's kind of a more optimistic topic, so maybe that's good to do at the end of this. But so once you've gotten a positive pregnancy test through blood levels or anything like that, I know a regular OB's office usually won't see a non-infertility patient until like 8 weeks. What does that gap look like between going to your office back to OB care?
Yeah, so I will, Kristen's chiming. I will do a scan, usually early viability scan around 7 weeks. And then I will typically bring you back for another scan in 7 to 10 or 10 to 14 days. So that'll get you to 8.5 weeks or so. You're right. Some OBs, and everybody's different. Some OBs don't even see it till 12 to 14 weeks.
Mm-hmm.
Some see it 10 to 12 weeks. I can't speak to their policies. I just saw a patient today who's 8 weeks, and she has an appointment next week with her primary. So everybody's different, but that's how I do it. If there's a history of recurrent pregnancy loss, and we say, I know the patient has gotten to 8 weeks in the past, and that's when she lost the pregnancy, I will certainly do most likely another ultrasound just to get her past that mark, because there's a lot of wellness in that as well, in terms of peace of mind, to get past the previous mark that you had before. So I appreciate that. And if she doesn't have an appointment with her OB, I will 9 times out of 10 do that. I just did that today as well in terms of rescheduling, just because of her history. So, but I usually get 2 ultrasounds, and after 2, if you still have good growth and heart rate, your chance of miscarriage decreases significantly. It never goes to 0, but it decreases significantly.
Stay with them as long as you can.
What's that?
I said stay with them as long as you can, because they follow you so much more closely.
Mm-hmm.
You get so pampered being, you're like constantly getting checked up on, and then once you graduate to OB, you're just an OB patient after that. And you really don't get that many ultrasounds.
It's so true. That's really funny. But then what's funny is at the end of your pregnancy, you become that close with your OB's office, and then you leave them again. So it's like, it happens there too. But yeah, no matter what practice you're at, they're generally going to be like Dr. Likes, just with my experience with working with other patients or clients of mine. And stay with them for as long as you can and try and get as many ultrasounds as they'll let you if you're nervous. But the 2-week wait is really hard. I came up with a 2-week wait challenge. That's what started me into this, because the 2-week wait was really hard. I didn't like that. And then I realized that after the 2 weeks, the time between ultrasounds was worse. And so your question, Jordan, is totally normal. And everybody who's in that is, again, you're just getting to that point until you hit the end zone. So my point on that emotional part, to not super stress yourself out, but one is, the key is to spend your time thinking about what you want, not what you're trying to avoid. Because if you think about it, it's like you're praying for what you don't want versus praying for what you want. So spend the time thinking, believing in what you want. And the second one is, the time is passing sort of no matter what. You have the choice to make it a good experience, to document it, to have it be fun, and be hopeful until you sort of have a reason to not be hopeful. I know it's hard and really scary to do that, especially if you've had a loss already. I know that it's so hard. But when it does work out, if you spent the whole time being nervous, a lot of women then say that they get so mad at themselves because they didn't experience it or enjoy parts and pieces of it. So I just want to share that aspect too. And I hope that's helpful.